1st, 2020 Study and Formulating Committee meeting. At first of the meeting, I would like to go ahead and take a roll call for a quorum. If you could just unmute yourself, announce your name and say yes if you are present. Nick Brassel.
Yes.
Richard Chapman.
Yes.
Cleophas Rucker.
Yes.
And Kim Stagg.
I'm here.
Thank you. Next up, I am going to go ahead and read the electronic meeting statement. And then if everyone on the committee agrees, we will also take a roll call vote to approve that. And also, if a person is using audio only participation, wishes to speak, he or she shall identify themselves in a manner reasonably calculated to permit the public to ascertain the identity of the person speaking. As a result of the COVID-19 pandemic, the governor issued Executive Order number 16, extended by Executive Orders number 34, 51, 60, and 65, authorizing boards to meet and conduct their essential business by electronic means if the board determines that meeting electronically is necessary to protect the health, safety, and welfare of Tennesseans in light of the COVID-19 outbreak. So before considering any items on the agenda, the board will need to determine by roll call vote that the meeting agenda constitutes essential business of the board and meeting electronically is necessary to protect the health, safety, and welfare of Tennesseans in light of the COVID-19 outbreak. And we will record these votes by roll call. So Mr. Nick Brassel.
Yes, I agree.
Richard Chapman.
I agree.
Cleophas Rucker.
Yes, I agree.
And Kim Stagg.
I agree.
Perfect. Next, we want to go ahead and approve the minutes from the October 30th Study and Formulating Committee meeting and the November 12th Study and Formulating Committee meeting. So is there a motion for approval?
I move we approve both sets of minutes.
Thank you. Is there a second?
I'll second.
Second. Go ahead.
Okay. All right, and let's take a roll call. Nick Brassel.
Yes.
Richard Chapman.
Aye.
Cleophas Rucker.
Yes.
And Kim Stagg.
Approved.
All right, thank you. All right, moving on. As you all are aware, our board chair, Trish Holliday, has unfortunately moved out of the county, but maybe that's something she was wanting to do. I'm not quite for sure, but I just wanted to say that moving out of the county does make her ineligible to be on the committee anymore. So we want to thank her for her diligent work that she has done for this committee. And at the end of this meeting, we would like to see if there is an election of a new chair or election of a new vice chair if that vacancy arises. So we will conclude the meeting with that. But first up, I want to get an update. I know the last meeting, there was some discussion around the guaranteed payment plan. And we were going to get an update on the funding of that from our legal advisor, Nikki Eke. And then I believe Kevin Sullivan from Finley, our actuarial consultants, may have some information to add on that as well. So Nikki, I will go ahead and turn it over to you.
Thank you. I just basically wanted to indicate that there is a state statute that governs the funding of the guaranteed payment plan. And under that state law, Metro cannot reduce the current funding of the guaranteed payment plan or reamortize the funding of the guaranteed payment plan. And so essentially the current yearly funding is required to continue until the plans are fully funded under state law.
This is Richard Chapman. I have a question. Nikki, does that mean that when the plan becomes fully funded in approximately 3 years, Metro can stop its contribution?
Yes, yes.
Okay. And what's the code citation for that?
The code section is Tennessee Code Annotated 73105.
Okay, thank you.
I don't know whether Kevin Sullivan wants to add additional comments.
Yeah, I'll just provide a couple of quick comments, maybe tying what we've talked about now with what we talked about last time with the guaranteed payment plan. So, and Mr. Chapman, you kind of hit a key point where our last discussions, we were talking about 4 years remaining as of June 30, 2019. So we're actually a little more than a year removed from that date. So we're probably under 3 years remaining at this point of the $33,577,000 annual payment to the guaranteed payment plan. So while the ability to re-amortize it and draw that out over a longer period and reduce the payments is off the table based on this code citation, we still have the issue of the plans are expected to be fully funded in less than 3 years, freeing up those dollars for other purposes.
This is Dick Chapman. I want to make sure I got the date and the amounts right. That was 4 years as of 7/1/19.
Correct.
And the amount is?
I can pull up the exact amount, but I believe it is
a close number.
Look, $33,577,000.
Is that the entire amount, or is that the annual amount?
That's the annual amount.
Okay. Thank you.
And as one other comment I'll make, as I mentioned last time, you know, when you pay it, when you fully fund a pension plan, really any pension plan, the very next day you're going to be either a little overfunded or a little underfunded. So presumably these plans would then fall under the same rules that apply to all other public pension plans in the state, which means you can amortize any new unfunded liabilities over a reasonable period of time after that date.
Okay.
Are there any other questions?
Mr. Sullivan, this is Dick Chapman again. I want to confirm that's $33 million.
That's correct.
Approximately. Okay.
Correct.
Thank you.
Okay. Well, if there are no other questions, item number 1, we will move on to item number 2. Which is the healthcare strategy recommendation to address OPEB. And Kelly Lewis is sharing her screen right now with us, and she'll kick it off for us. Kelly, you might be on mute.
So this is Angela, and yes. Kelly and I are going to present this information to you. I will begin. So Kelly, I'll pass it over to you shortly. Thank you very much. We rushed through some of these slides last time with you. So the plan for today is to start over from the beginning and go through slowly, methodically, so the committee can have hear us present the full slides that we have prepared. And of course, most importantly, have time throughout and at the end to answer your questions. So the topic, as Christina mentioned, is the strategy recommendations, which we do have 2 recommendations at the end of the presentation to address the OPEB liability. Okay, so the first thing that we wanted to share with you today is exactly what is OPEB. And you'll recall that the reason we're discussing this is because it was noted by Kevin Crumbo on one of the first meetings that this is the #1 focus for the administration, which is the OPEB liability, which you can see there is $4.2 billion as of July 2020. And that liability is completely unfunded, unlike the pension plan, which Kevin shared last time is north of 95% funded. So here, OPEB stands for other post-employment benefits, and these are the benefits that employee will begin to receive once they have retired. It does not include the pension benefits that Kevin spoke to just a short time ago and on the last meeting. It does include what's shown here at the bottom of the slide, health insurance. These are provided by Metro to the retired employee. So health insurance, Metro pays 75% of the cost of the medical coverage once retired. The asterisk refers to the footnote there, and you may recall on the last meeting that Christy Mayo from Metro HR shared that there's now an indexing since 2013 of the retiree medical premiums depending on the number of years of service retiree has upon retirement. So there is a index schedule. Then secondly, dental insurance, where Metro pays 100% of that cost for single coverage. And then life insurance, Metro pays 100% of the cost to provide $10,000 benefit there. So that, any questions there about what OPEB either is or is not? Okay, great. And then back to this memo from September 25th, from Kevin Crumbo and Kristen Wilson. There were 4 medical issues or items that they wanted to raise attention to for purposes of the committee. So let's just run through them. The first one was to examine and make recommendations regarding the lower cost health plan option. We have been pursuing the discussion of this item with the benefit board. Kelly and I spoke with the board and presented to them both in the October and the November study sessions. We will continue to provide information on upcoming study sessions with regard to this item. Item number 2 is what we're here to talk about today, and it is to examine and make recommendations regarding migrating the retiree health plan options to plans that better maximize federal provisions for those age 65 eligible for Medicare, and specifically Medicare Advantage plans. The third item is reviewing if there could be optional incentives created for spending healthcare dollars as effectively as possible. For example, mandatory generic medications, tighter management of out-of-network costs. So here we have some information to share. First on, let me back up and say that Metro's PPO plan only has 2 tiers. So this is the Blue Cross Blue Shield PPO plan. It has 2 tiers for drug copays. By that, I mean there's a $10 copay for generic drugs and a $30 copay for all other drugs, regardless of how expensive that drug may be. It could be a $10,000 drug and it would be $30 copay for that individual. And you can see here that in the Blue Cross EPO, there's 85% generic utilization, which is slightly below the Blue Cross Blue Shield overall book of business. They do offer several programs to help employers manage their overall drug spend. And over the last few years, Metro has implemented some of those programs, including an opioid management program. And then with the Cigna Choice Fund, which is the other option, this plan was designed specifically to drive consumerism, known as a consumer-driven healthcare plan. And it's a plan that does not have copays. So its design does tend to result in a higher utilization of generic drugs. And in fact, you can see here that 92% utilization is in generics. And that's actually slightly greater than Cigna's book of business norm, which is that 90.4%. And then just there at the bottom regarding out-of-network costs, because that was also mentioned, Metro's contracted with both carriers, Blue Cross and Cigna, to utilize the broadest networks across, and only a very small percentage of members go out of network because the networks are so broad. And you can see a 2.4% and 2% respectively, Blue Cross and Cigna, as far as out of network claims. Okay. And then lastly, the fourth item is regarding providing recommendations on the expansion and reinforcement of availability of the use of wellness initiatives. And we will continue to evaluate strategies and next steps available to Metro to address these concerns and bring to this committee at a later date, depending on how time permits, given the committee's appointment timing. Okay, so switching back to the item at hand today on Medicare Advantage, the strategy here to address the OPEB liability is centered around offering Medicare Advantage plans as the sole option for pensioners with Medicare. And just to clarify that, this would apply to pensioners who have Medicare and for those who are covering their dependents that also have Medicare. So this would not apply to any pensioners who have dependents that are not eligible to Medicare. The pensioner and their dependents would need to be eligible for Medicare. And the benefit of this strategy is that it provides significant financial savings to both the pensioners and Metro. So it's a win-win to both groups. And it maintains the comprehensive medical coverage to which Metro pensioners have become accustomed to all these years. So here in the graphic, you'll see that there's the $4.2 billion unfunded liability for the OPEB benefits is the concern. The strategy is to offer the Medicare Advantage plan as the only choice for pensioners who have Medicare and that their dependents are eligible for Medicare. And this results in significant savings for both Metro and the pensioners. The 14 million there is, Kelly will get into this a little bit further, but if this recommendation had been implemented for 2021, the estimated savings for 2021 would have been, is $14 million if it had been implemented. Also, because there is such a difference in the premiums between the Medicare Advantage plan and the Blue Cross Blue Shield PPO, the Cigna Choice plan, that results in the $14 million savings. It also reduces the overall $4.2 billion OPEB liability by $1.1 billion. So almost a quarter of the OPEB liability will be reduced. And these calculations are from Findley and the health actuary for the plan. So pretty astounding potential here. Okay. So moving on. I know this is a lot of information, but let's keep going. If you have any questions, please let me know.
I have a question before you move on. This is Dick Chapman.
Yes, sir.
The savings that you're projecting, does that include the implied subsidy of the retirees based on the fact that on a per capita basis, they're substantially more expensive than the overall group?
So let's see. So I believe you're talking about the under age 65 retirees.
Well, it would include the over age 65 as well, but in this instance, Medicare is primary. So the savings is not nearly as, the reduction is not nearly as dramatic because you're already carving out the value of Medicare coverage itself.
Right.
Okay. I think I've answered.
I can step in if you want.
And sorry, I think we have Joe Myers from the phone. And
Can you guys hear me okay?
Yes.
Yeah, just to answer your question, the savings in the presentation is the savings including any implied subsidy. So it's the true savings of going to the plan.
That's where the 1.2 million is.
Yes,
Okay.
billion.
Sorry.
Yeah.
Thank you.
Thank you for the question, and thank you, Joe, for confirming. Okay, so the plans currently available to Metro pensioners, as it stands right now, that are Medicare, that have Medicare, it's that Blue Cross Blue Shield PPO, and it has an employer group waiver plan. This is an 80-20 coinsurance plan, which means that most of the non-preventive services are covered at 80% when they're in network. This employee group waiver plan is administered by Express Scripts, and it provides coordination of the PPO plan benefits with the Part D prescription drug benefits. This plan is self-insured by Metro. Secondly, the Cigna Choice Fund. This is that consumer-driven health plan. It combines the traditional medical coverage with a Metro-funded health reimbursement account fund, an HRA fund. Pensioners with Medicare Parts A and B do not receive the HRA fund because they're not eligible for it, but they can continue to use any accumulated unused fund balance after they have the eligibility for Medicare. This plan is also self-insured by Metro. And then lastly, there's the Humana Group Medicare Advantage plan. So this is a PPO with a prescription drug coverage. It's not a supplement plan, a Medicare supplement plan that you might have heard of. It's a Medicare Advantage plan, and it provides a combination of that Medicare Part A, which is the hospital coverage, Medicare Part B, which is the outpatient or medical coverages, and it also includes supplements that are noted here, home health care, et cetera, and it has the prescription drug component as well. This is fully insured by Humana, as opposed to the other two that are self-insured by Metro. And that'll be important in a few slides when we talk about more about the cost savings. Okay, and
Angela, I have a question
Yes.
for you.
Sure.
Does the dental coverage under the Medicare Advantage plan duplicate the dental coverage that Metro is taking care of 100% of the cost of that coverage?
That is a good question. Kelly.
Yes. The dental coverage that is in the Medicare Advantage plan is limited. It's really 2 cleanings a year. So it's not as robust as the Metro coverage. So the Metro coverage covers, other things such as implants and, a host of crowns and things of that nature. So the dental coverage, it's great because it does have some in terms of like cleanings and x-rays, but it's not as comprehensive a coverage as Metro's dental coverage is.
Okay, thank you. One note at the bottom before we move on, if there wasn't a follow-up to that, the board adopted and made a code language changes into the Metro code with regard to this employer group waiver plan that is regarding the Part D prescription drug coverage component of Medicare, and effective in 2014. And so that language was added into the code at that time for this group waiver plan. That's important so that it can coordinate with the Blue Cross Blue Shield plan. That's going to be important because if the committee wants to pursue this recommendation that we have, there will be a code cleanup to remove that language that will be necessary. So we'll come back to that later when we share the full recommendation, but wanted to note it here so you'll be aware of it. Okay, so next. I wanted to quickly review the current enrollment of the pensioners in the Metro plans, medical plans. Right now, Metro covers just shy of, this is as of August 2020, I should say, so a few months old, just under 6,400 pensioners that are with Medicare eligible members. And only 33%, if you look at the table at the bottom, the first row, 33% choosing to enroll in Metro's Medicare Advantage plan, which is the Humana plan. We just went through annual enrollment at Metro, and that ran in October, and there was very little shift in these numbers, like very little to no shift in terms of pensioners with Medicare electing to move into the Medicare Advantage plan. There's a lot of brand loyalty there to Blue Cross Blue Shield and or Cigna. And here are some quick numbers. So in 2021, pensioners that were in Humana, the Medicare Advantage plan, pay significantly less in annual premiums than those in the other two plans, to the tune of almost $725 less per year than the Blue Cross PPO, and over $1,000 less per year than those enrolled in the Cigna Choice Fund. So there, the second row of the table, just for point of reference, that's the number of pensioners with Medicare that also have covered dependents with Medicare. So the grand total, that would, instead of the 6,400, there's over 8,500 when you include dependents.
Hey, Angela, this is Kim Staggs. So the number there, the $723, that's the 25% of the cost that the pensioner has to pay.
Actually, that's correct.
Right, okay.
That is the savings that the pensioners in 2021, the pensioners' 25% portion that they're paying out of their pension check.
Right.
Yes, that's correct.
Right. Okay.
Yes, it's the difference in the premiums of their portion. Yes. Okay. Great.
Angela, this is Dick Chapman again. Does this take into consideration any of the co-payments or co-insurance that's going to take place in the Medicare Advantage plan?
So these numbers here do not.
Okay, so it is pure premium, not benefit differences, because when you coordinate the Blue Cross PPO with Medicare, you basically have 100% plan from a benefit standpoint. No.
Well, the numbers here do not know copay wise or deductible. This is just the difference in the amounts of premiums.
Okay.
The 14 million savings that we shared earlier that Kelly's going to share more on in just a few slides, that actually didn't include differences in copays or premiums either. It would actually be more than $14 million in savings if this had been implemented, if you account for the differences in the copays and deductibles.
Let me just see if I'm making the right point.
Okay.
When Medicare and the Blue Cross PPO finish processing charges against something that a retiree has used, it's basically going to be 100% payment because of the way coordination works. Right?
Yes, to some degree, and I think we're going to look at that. There's a slide that we're going to look at shortly, and I think will clarify that question.
I'm covered by a Medicare Advantage plan, so and only that. So part of my reference is I pay a copayment, I pay a co-insurance at various points in time. That's not included in this number.
True, but I will also say that Metro's Medicare Advantage plan was designed. It's not a off-the-shelf Medicare Advantage plan. It is one that they tailored And so it's not just one that the Humana came to them and said, here's a
I got you.
popular. Okay, so, all right,
What you're saying is it may be a little more generous benefit
then yours.
my Medicare Advantage plan from Blue Cross. That's the Ruby level in case you want to check me out for the next time we talk.
Yes, Mr. Chapman, that's a good point. All three of the plans that we reviewed a minute ago, the Blue Cross Blue Shield, PPO, the Cigna Choice Fund, and that Humana Medicare Advantage would be called the Cadillac plan. They're all extremely rich compared to others in the marketplace, and that does include that Humana Medicare Advantage plan.
Yeah, I understand what you're saying.
Okay.
So Angela, this is Cleo Rucker. I had a quick question. So does that mean that the three different plans have similar networks as well, networks of doctors?
I believe so. Kelly?
Yes. So the Blue Cross, the Metro has contracted with Blue Cross for Blue Cross's, they call it their Network P. It's an extremely, it's Blue Cross's broadest network in the state. Same with Cigna, they are Cigna's broadest network. In Humana, so the members, if they're going to a doctor, these plans that
Hey,
the
Kelly.
members in.
Kelly, can I just, I'm sorry to interrupt you, but we're getting some feedback. So if everybody could mute unless you're speaking, I don't know if everybody else is hearing the same thing I am, but that would be great. Thank you.
Okay, is that better?
That's much better. Thank you.
So for Metro's members with Medicare, if their physician accepts Medicare, then it's not going to matter, which of the plans that they are in. If that, I think, maybe answers your question, Mr. Rucker. There was some feedback. So
Yes, thank you.
Okay.
Okay. Well,
Kelly, your answer just implied to me that if Metro pensioners have to go to a Humana Medicare Advantage, they will see a limit in the preferred providers that are available to them.
No, that's not the case. There's a slide so with Metro, again, Metro designed their Medicare Advantage plan. It's not one that Humana or someone else designed, but they're same for Metro members. There's the same out-of-network and in-network coverage. So if, for example, a member's doctor was not in Humana's network, as long as the provider accepts Medicare and is willing to bill Humana, the individual can go to that person. So it's not like Humana necessarily has a network. The doctor just has to be able to accept Medicare and be willing to bill Humana if they're not in Humana's network.
Do you know how many physicians on the who are in network with Blue Cross Blue Shield do not accept Medicare?
Well, if the Metro pensioner who's got Medicare is in the Blue Cross plan, I doubt they would be going to a doctor that doesn't accept Medicare. Can't think of a reason.
So here's why I'm asking. If this committee gets behind your recommendation and the savings are significant, the biggest question we're going to have is pensioners who say, my Blue Cross Blue Shield in-network provider will no longer see me because he or she doesn't accept Medicare. And so that's why I'm asking the question. I want to be able to say, no, everybody who is in network Blue Cross Blue Shield will also take your insurance under Humana Medicare. And I'm looking for the evidence to support that kind of statement.
I'm going to ask, just because I know she attends a lot of the in-person, not this year, but you all have had a couple of presentations by Christy Mayo from Metro Human Resources, and she does a lot of interactions with the pensioners at these Metro's annual enrollment fairs as they're trying to help the pensioners evaluate their decisions. And Christy, I don't want to put you on the spot, but in the last few years that Humana has been in
Hi, Ms. I hope y'all can hear me okay. Do you mind asking your question one more time? I want to make sure I address it correctly.
My question is this. I understand the Blue Cross Blue Shield PPO plan has a list of in-network physicians. So I'll give you an example. The head of the major cardiology unit at St. Thomas is in-network at Blue Cross Blue Shield PPO. Can you tell me the same in-network physicians under the Blue Cross Blue Shield PPO will also accept Medicare and the Humana plan, or will our pensioners be penalized and limited in the physicians they can see who are in network if we tell them everybody has to go to Humana?
Okay.
Here's the question I'm afraid we will hear from a pensioner. I see the top cardiologist at the best heart group in Nashville, and he's in network with Blue Cross Blue Shield, or she is. And if I have to go to Humana, he or she's going to tell me I don't accept Medicare and I won't accept Medicare Advantage. I need to know if that's a valid concern.
I hear what you're saying and I understand your question, and I do not believe that it is a concern. I believe, and Kelly confirmed too, that this is correct, but I know that there are some doctors, even if you have Blue Cross or Cigna, there are some doctors who, I have a doctor, for example, even though I don't have Medicare, they will not see any Medicare patients. So they have the right to, I guess, make that decision for their practice or for themselves. But we have not seen that or heard that with the Humana plan. That's not been something that any of our members have expressed concern with. I know that Humana says that you can see any doctor you want to see as long as they accept Medicare and agree to bill Medicare, even if that doctor does not have a relationship with our current Humana plan. So I don't believe that that is a concern. I have not seen that or heard that for the last several years that we've had Humana.
And Chris, can Humana provide us some hard evidence to say no one will be told by their doctor if they move from Blue Cross Blue Shield to Humana Medicare Advantage that they have to go find a new physician?
Well, let me say a couple of things, and Christy's kind of. I think first of all, let's with pensioners in Metro's PPO plan, Medicare is primary. So Metro's PPO plan pays secondary to Medicare. So if this pensioner is going to a top cardiologist who is saying, I don't accept Medicare, then they're going to be paying an awful lot, because a Metro pensioner with Medicare, Metro's plan pays secondary. So I don't know that someone would want to choose to go to a doctor if they're not accepting Medicare, when Medicare is that pensioner's primary insurance.
Okay,
and then the second thing that I also want to kind of even though we're calling it the Humana Medicare Advantage plan and the Blue Cross PPO plan, it's more important that we focus on just the type of plan, because Metro has to put their medical plans out for bid every 5 years. And it could be when these plans are put out to bid in, the next year or year and a half when they're put out, it might not be Humana that's insuring the Medicare Advantage plan. The competitive bid could come in from Aetna, Blue Cross, Cigna, United. And so it's just that, and Metro, as I was saying earlier, they dictate the design of their Medicare Advantage plan, so that they really offer, in terms of a Medicare Advantage plan, a Cadillac Medicare Advantage plan. So they will get competitive bids. And so it's not, it may not be Humana in the next, contract bid, and it may not be Blue Cross that has the PPO plan the next time. So it's that's just something that we, to keep in mind as well.
This is Dick Chapman. Kim, let me. I've actually helped run a health insurance plan previously, and there's other areas in addition to physicians. It's like, what's going to happen with the hospitals? Because in Nashville, you've basically got at least 3 sets of hospitals and some others. You got the HCA group, you got Vanderbilt, and you got St. Thomas, you got Metro General and several others, and different networks are going to have different hospitals, which are also going to drive all of the specialty care and the established relationships with them. And the broader you make the network, the more expensive you're going to make the coverage, because the network has less leverage with the hospitals to drive down prices. So, I mean, that's a very practical kind of answer, because employees want access to all providers, no deductibles, no co-payments, no co-insurance, and low premiums. It doesn't work that way. Or it doesn't work as well that way if you're trying to control the cost to the retiree.
Right.
I'm done.
Ms. Staggs, this is Christy Mayo again. I also wanted to add that even though we may not have Humana next time we put our insurance out to bid, Humana has put in writing in all of our communication materials that you can see a doctor even if they're technically out of the Humana network. So they have put that in writing for us.
Okay. And so, Dick, your point is a very good one. And I see the goal of this committee to not only make recommendations, such as only making the Humana Medicare Advantage plan available to pensioners, but also helping the Metro Council and the pensioners understand why that's best for everyone. And I think getting the evidence about the fact that they don't have to change doctors, they don't have to change hospitals if we impose this change. Getting at the evidence that says, here's a comparison. If you had a heart attack under the Blue Cross Blue Shield PPO plan this year, here's what your out-of-pocket would be. If you were under Medicare Advantage, here's what your out-of-pocket would be. And look, it saves pensioners money, and you don't have to change hospitals, and you don't have to change doctors. And if that evidence is available, I think it's our job to find it and collect it and turn it over with our recommendation for this.
And I agree with you wholeheartedly, but I think we also have to put a proviso in there that basically says these plans are going to be subject to the same kind of competitive procurement processes that would take place anyway, and we can't make this promise for the future ongoing forever. Because I think you got to tell the council in these instances that what all the facts are, because these things are difficult. And I think we're going to find out, for example, that maybe not all the hospitals are in the Humana network. And as a consequence, that impacts, everybody. I think unless this is so generous or rich an option that it doesn't matter. And that Kelly and others have made the point, that may be the case.
I would like to recognize.
Christy, I think all of the.
Can you hear me?
I'm sorry, Christine. I was just going to say.
Go ahead.
I believe, Christy, I mean, you can confirm, but all of the Nashville area hospitals, the pensioners in the Humana Medicare Advantage plan have access to, and the coverage, again, is the same in network as out of network. We're going to look at shortly, we're going to look at the plan design of each three plans side by side, so that you can see, I mean, as Angela, this slide here is really talking about the premium savings, but we're also going to look at like out-of-pocket cost for the Humana plan versus the others.
Kelly, you are correct about the hospital networks.
I did want to recognize Director Shannon Hall. She has her hand raised.
Thank you, Christina. Just want to kind of tie together a couple of points that I think Mr. Chapman and Ms. Stagg both raised. Just so you know, Metro requires all pensioners who are Medicare eligible to take Parts A and B. That is a requirement of the Metro plan, has been for decades. So as a result, regardless of what plan you participate in, because Metro requires pensioners who are Medicare eligible to take Medicare Parts A and B, getting to a physician that accepts Medicare, you will face that regardless of what plan you're in. So I think that's one component. When you couple that information with the information that Christy and Kelly have shared about the Humana network, because you can go in and outside of the network and receive those benefits, there should be any kind of meaningful network impact to the member. Because I think, Kim, as I'm sure most of us have experienced in our life through our own insurance, networks, and whether they're hospital networks or physician networks, matter. Mr. Chapman brings up a really good point, which is, the broader the network, typically that drives cost because you can't leverage and drive your members to a particular hospital, area hospital where they get all the business. I will say historically, and this is my experience, I'll certainly welcome Christy's comments because her history with Metro benefits is longer than mine. But in my time here, I think the Employee Benefit Board has really valued the idea of network choice for their members. And that's been very consistent across all plans, whether it's the self-insured PPO, the self-insured account-based plan, our previous HMO, which is no longer part of this, and our Medicare Advantage plan offerings. I will say, at least internally, we have more recently even looked at the impact of going to a narrow network as a potential cost containment strategy. And it's very interesting that those cost containment measures are not nearly as impactful as you would believe them to be. I think when we've looked at it most recently in the past 6 to 9 months, at least internally, through some of the great work that Deloitte's been able to provide us, the networks narrow considerably without a huge cost decrease, at least from a hospital corporation component. The other thing we're also trying to balance, especially for our pensioner group and now our employee population, is that as housing prices have gone up, more employees at times have had to reside out of county. As many of us know, most of the surrounding area hospitals near someone's home are most likely HCA and less likely to be a Vandy or St. Thomas. Typically, we've seen, and it's pretty different for each plan, they'll exclude a major hospital network. Sometimes that's HCA. Sometimes in the past, we've seen that be Vandy. But it seems like, at least with the administrators we have right now, the exclusion of HCA seems to be the more prevalent trend for right now, although we do see that change. And so we really don't think that while there is a cost containment factor on the narrowing of hospital networks, they don't seem to be meaningful. But I want you to know lots of those nuances we are studying internally, that the Employee Benefit Board, when appropriate, is evaluating and really doing their due diligence. But in the past, consistent with how we bid these plans, network and provider choice for our employees and pensioners has been a highly valued item, both for the employee and pensioner base, as well as the Employee Benefit Board making those decisions.
All right. So if we're okay, we'll move on. And I think we have a few more slides that I think that will continue to help answer and support some of the questions that have come up. So as you are considering the possibility of having the Medicare Advantage plan being the sole solution for the Metro pensioners, we've got some facts and some information about these types of plans and their growing popularity. Over the last 10 years, the number of members in Medicare Advantage plans has increased from 11 million to 22 million. The Congressional Budget Office projects that 47% of all Medicare enrollees will be in a Medicare Advantage plan by 2029. The majority of employers who do still provide group medical coverage to retirees have moved to group Medicare Advantage plans. With the Medicare Advantage carrier, whether we've listed 4 or 5 of the top national ones here, but they take on all the functions of Medicare. And so retirees really only have to deal with 1 administrator versus 2. For example, a Metro pensioner in Metro's PPO plan actually has to deal with 3 administrators. They have to deal with Medicare first because Medicare pays primary. Blue Cross pays secondary. And because Metro has the employer group waiver plan to provide the Part D coverage in the PPO plan, and Express Scripts is the administrator for the EGWP Part D, a Metro member has 3 cards and 3 administrators to have to deal with. So a lot of simplifies things greatly for the pensioner. And then Medicare Advantage plan, PPO plans typically reduce costs through 2 principal mechanisms. And it's those reduced costs that will translate to the lower premiums that these plans have. And the plans receive greater federal subsidies for enrollees with chronic conditions. And so when Metro put their Medicare Advantage plan out to bid, I guess 4 years ago, Humana, part of the evaluation process was the CMS star ratings that Humana had. And that will be something that they continue to examine and look at with the next RFP cycle. So how do Medicare Advantage plans work and why consider? They are all-in-one alternatives to original Medicare, and they are offered as fully insured. They're approved by CMS. They cover all Medicare services. And they, as Angela was saying earlier, they even have coverage that original Medicare does not have. So dental coverage, vision coverage, some hearing aid coverage, and some health programs like Silver Sneakers and Silver Fit. For Metro, obviously it's a win for Metro because it will deliver significant cost reduction to their pay-as-you-go cost, so that current year premium cost each year, as well as a reduction to their OPEB liability. And it may ultimately support the longevity of Metro's benefit system. Obviously, the cost of Metro's benefits is something that they want to maintain and offer competitively, but so that it's sustainable for the future. For the pensioner, it is more affordable. Lower monthly premiums means it's going to increase the amount of their monthly pension check that they receive from Metro. Ease of coordination, as I just mentioned, it's one ID card versus three that those in the PPO plan currently have 3 ID cards. There's no change in member share services, whether they go in our network or out of network. So that's huge. And it's something that Metro Human Resources tries to promote each year in the when they do their annual enrollment communications. Then there's supportive care management and benefits beyond Medicare are a potential advantage. And that is also those perks and those extra benefits are things that the Metro benefits team that will do the RFP, they look at what are the other benefits. And for example, currently Humana members, they have one of their programs is when a member's released from the hospital, they get up to like 10, or I think it might have been increased to maybe 12 or 14 dinners delivered to their home after they're released from the hospital, if that's something that they would like. And so for someone who's elderly, maybe lives by themselves, that's a huge benefit. And then there's one point of contact for medical and pharmacy questions and issues, again, which is different for those in Metro's PPO plan that has one point of contact or for medical and one for the pharmacy. So we've talked a little bit about this, so I won't belabor this, but the chart shows the annual premium savings, as Angela was mentioning earlier, but there's going to be other cost reductions and savings that those pensioners could see as well, simply because of the plan design. And I think that will be the next slide. Metro would have paid about $14 million less in having to fund the plans next year to pay for claims. And then it would reduce the OPEB liability by approximately $1.1 billion. If you recall, I think at the November 12th meeting, Christy Mayo.
This is Dick Chapman. I have a couple questions. Can you roll back one slide, please?
Yes. Yes.
Okay, and this has no impact on the pre-Medicare retirees at all.
Correct.
Okay.
Pre-Medicare retirees would continue to either be in the PPO plan or the Cigna plan.
And because this is fully insured, this gets back to an OPEB calculation. Because this is fully insured, Metro's obligation is reduced simply by the financial status of the coverage.
Of the cost of the coverage? Of the premium savings? The premium savings or?
No. Because the coverage is fully insured as opposed to self-insured, part of the savings that's out there at the $1.1 billion amount is because of the status change of the plan not being obligated for any overages. So if, for example, if Humana misses the estimate on the costs, that's Humana's responsibility, not Metro Plan's responsibility.
That is correct.
Okay. Where in the current status, it's still the same because it's fully insured now. Got it. Okay. I'm done.
Okay. Yes. So on this slide here, as Christy Mayo had discussed at the November 12th meeting, back in 2013, Metro implemented several changes, and one was to index for those individuals, I will just see, let me look at the date. I think it was people hired as of 2013. As they retired, they would not get the current pensioners now only pay 25% of the cost of coverage. Metro pays 75%. But for those individuals hired on or after January 1st, 2013, their medical premiums are going to be based on the amount of credited service they earn. So in this example, we're going to say if there had been someone hired after 1/1/2013 and they retired with 10 years of credited service, they're going to be paying 75% of the cost of their Metro health insurance compared to current retirees who are only paying 25% of the cost. And using what we know, because we know what the 2021 rates are, so just using those rates, if that pensioner who had to pay 75% of the cost of their health insurance, and they chose to be in the Blue Cross PPO plan versus the Humana plan, they would be paying almost $2,200 more in premiums for 2021. And if they chose to stay in the Cigna plan versus move into the Medicare Advantage plan, they would be paying almost $3,200 more just for the privilege of having the insurance. That's not covering any, claims or cost of service. That's just simply to have the insurance.
So the point that this example that Kelly just went over makes is that because of that premium indexing, depending on the years of service, there's even more savings available to the retirees that have, say, 10 years of service, credited service when they retire, 11, 12, as opposed to, because they're paying a greater percentage of the premiums because of the indexing.
So, any questions before I move on?
This is Dick Chapman again, but the point is those premium savings, because the retiree is going to be paying an increasing portion based on the sliding scale, those actually go back to the plan and ultimately Metro and the active employees, because that's where the subsidy comes from, right?
Well, the subsidy is not coming. It's not coming from the actives. It's Metro paying it out of the I guess the general.
They're paying it out of their 75% as the employer, but the active employees are also paying 25%, and to a certain extent, that money's funneling through in basically the giant fund.
Correct.
And the same would apply to the retirees that are pre-1/1/13, because everybody's on the same big pool of money. Yeah. Okay.
Okay.
Bye.
So this is a page that I think will answer some of the questions that were raised earlier. And members are going to pay less for most medical services in the Medicare Advantage plan versus the PPO plan and that choice fund. If you look, so the annual deductible, the Medicare Advantage plan has no deductible. So it's coverage from day one without a deductible having to be met. Same as the Blue Cross, it also has no deductible, the PPO plan. The Cigna Choice Fund does have a deductible. The annual out-of-pocket maximum, you can see, is the same for the Medicare Advantage plan as well as the PPO plan, $1,000 per person. The Cigna Choice Fund has $1,150 for single and $2,300 for family. What is great is for a member who ends up in the hospital and they've got the Medicare Advantage plan, they have no deductible to be met. they have no coinsurance, and they have no copay. So when they go to the hospital, they are not going to be paying anything for that hospital stay. Whereas Blue Cross members would have whatever Medicare doesn't pay, then they would be having to pick up the difference, and they've got that 20% coinsurance until they hit their out-of-pocket maximum. Primary care visits. So when you're going to see your primary care doctor and you've got the Medicare Advantage plan, it's just a $10 copay versus the PPO plan, which has a $20 copay after the 20% coinsurance. Specialist visit is cheaper with the Medicare Advantage plan, and then an emergency care, emergency room visit is also cheaper.
Hey, Kelly, before you move on, would you share about Metro's current admin practice, administrative practice, if an active is over age 65 and then they retire, currently works?
If they retire during the year and they're over 65?
Right, they wait until the following annual enrollment cycle to be able to go into a Medicare Advantage plan. But under what we're proposing here, the first of the month after they turn age 65 and they're eligible for Medicare, they would move into this Medicare Advantage plan and start benefiting these savings.
So as they age into Medicare during the year, then they would be able to move, they would go directly into the Medicare Advantage plan under our new proposal, and this, if the committee decides to move forward with this. During our last meeting, I believe there were a couple of the committee members that when we got to the end, said, what are some of the other cost reduction actions that have either been taken by Metro's other peers or counties or even the state of Tennessee? And so we have listed here, this is not an exhaustive list of all of Metro's peer cities and counties. This was just a list that you probably recall, I think at one of the first meetings that we presented with you all, we had this information on some benchmarking. And it's just some of the cities that had their information readily available without us having to go do FOIAs and get any type of information from them. So you can see that Cincinnati, Dallas, and the state of Tennessee have eliminated retiree medical as a benefit to new hires. So it's no longer as a promised benefit to new employees. There have been others that have taken the route of once a person is eligible for Medicare, they no longer have any coverage through the employer. So this is for those who retire early. You know, they allow them to keep retiree medical, but once the person retires, qualifies for Medicare, they eliminate coverage. You can see number 3, many have chosen, and the majority have chosen that once a person's Medicare eligible, to either give them just either a Medicare Advantage plan, maybe a Medicare supplement plan, or a Medicare indemnity plan. Of these 3 types, the group Medicare Advantage plan is really the, and certainly the way Metro has designed theirs, much more robust and provides very comprehensive coverage for the pensioners. Some have, Memphis has chosen to move their retirees to an individual Medicare marketplace. And by doing so, they really just no longer even have to do any administration for them. So kind of off the books for the benefits department to take care of them. And then you can see that I believe Columbus, and this is for 2022. So they're not been put into practice yet, but they just voted to do this, was to eliminate coverage in their group health plan for both pre-Medicare retirees and retirees with Medicare, and just give them an allowance and a health reimbursement account and let them pay for coverage or claims or however they want to use that. So these are just some actions. Again, it's not a comprehensive list, but it's some of the most, probably about at least a third or half of what Metro's peers are doing. So to kind of wrap it all up, if you decide to move forward with helping, I guess, Metro really on those two top priorities of reducing the OPEB liability and migrating retirees to a plan like a Medicare Advantage plan, that recommendation could be effective for January 1 of 2023. And that would be the only choice for, those pensioners who have Medicare. And if they're covering a dependent, the dependent also has Medicare, that their only choice of health insurance through Metro would be a Medicare Advantage plan. And as Angela was saying earlier, that if you decide to move forward with that recommendation, the employer group waiver plan that's now attached to the PPO plan to provide the Part D prescription drug coverage in the PPO plan, the employer group waiver plan would no longer be needed. So there would just need to be some code cleanup, and Metro's code, to make code changes, I believe it requires coming from study and formulating to, I don't know if it goes to the board, then to the council. So there would just need to be some code cleanup to remove the language around the employer group waiver plan from the Metro code.
Mr. Mark Young has his hand raised. Mr. Young, you're recognized.
Thank you, Christina. Kelly, on the previous slide, you had Memphis listed there. I've been keeping up with what's going on down there in Memphis, and I believe I'm correct. They ran a referendum, increased the sales tax 0.5%, and it passed. And what it was for was to restore pension benefits. Is that correct?
So there was the teachers. So Memphis is a little bit different. I think that that referendum, and I may be wrong, it may have been the teachers. It could have been for a different segment, but I don't think it was for the general government employees. Now, I may be wrong. I will tell you that Memphis, a few years ago, actually eliminated the coverage altogether, not just for new hires, they just across the board did it. Then they got so much pushback, they switched and put them on the individual Medicare marketplace. Now, I did see that they had the referendum, but I was thinking that it had to do with some of the Memphis schools and that, but I can double check that.
Yeah, I think me and Brother Smallwood are sending texts back and forth.
Mm-hmm.
I think that they restored the benefits effective January 1, 2021 for public safety retirees.
Okay. So it was the public safety, not the teachers. Okay. I knew, but it wasn't the broader group of, I guess, their general government.
I think that's correct.
Okay.
This is Dick Chapman. I have a question on, in your cost reduction action number 1, it says eliminate retiree medical as a benefit to new hires. Does that mean even eliminating it for pre-Medicare retarees?
That is for
back one page. Yeah. There we go.
There we go. Yes, these. Well, Dallas and Cincinnati, yes, for all new hires. They're just no longer for even pre-65, just no longer offering retiree medical.
And the same applies to the state of Tennessee?
I don't know about the state. I don't know that that was for the,
because that's where I worked.
yes.
In the office that managed the health insurance and the benefits. And I remember in the mid 80s, we did away with post Medicare retiree participation in the health insurance plan, put in place a Medicare supplement plan that we partially subsidized and all those kind of things. And the law may have changed since then because all of that may have been done when we also changed the basic benefit structure for retirement, pension retirement. And I think that was around 2013 or something like that. So I may not, I'm probably not up to speed on what that means, but I would simply make the point, if you eliminate health insurance for retirees pre-Medicare, they've got a big exposure at that point. If they don't have any place else to get health insurance coverage, it's almost like you can't retire because you have this exposure out there. And in the case of public service people, I mean, public safety people, we want them to retire. We have a benefit structure for pensions that reflect the fact that you don't believe that people should be in a public safety position at certain ages. Now, you may use a point system to get there. You may use a required age opting out as a bona fide occupational requirement and those kind of things. But if you eliminate the ability of a public safety person that you've designed to benefit to kind of move them along, and you don't provide access to health insurance that's kind of offset by the younger workers and all those other kind of things, you really have prevented them from retiring.
I agree with what you're saying, and I believe the last study and formulating committee thought the same thing. I believe one of the recommendations of the last study and formulating committee was to possibly eliminate retiree medical as a promised benefit to new hires, except for those in public safety. And I don't, but I think there was, because, but I don't know that I think, I'm not sure what all happened with that, but I do agree. And I don't think that, I mean, that's not what a recommendation that we are making to Metro to eliminate retiree medical. Yeah.
But at the same time, yeah, I might argue that when everybody reaches Medicare eligibility, the public safety people have coverage through Medicare because they participated in Medicare just like general workers. And their needs at age 65 are probably not much different than the general workers. Now, I think you ought to cover everybody until you reach Medicare eligibility. That's just my opinion.
Director Shannon Hall has her hand raised. You are recognized.
Thank you, Christina. This is Shannon. Mr. Chapman, we 100% agree with you. There is a reason why, if you remember from our last meeting, this, while we know that OPEB and our unfunded liability is a fairly substantial one, eliminating health insurance for pre-Medicare retirees is just simply not an option and not something we would recommend. As Ms. Stagg had requested at the last meeting, this is our recommendation as far as a way to address this without sacrificing coverage and providing equity among all of our members. While it is definitely no secret that our pre-Medicare population drives the majority of our OPEB liability, we're trying to protect everyone in the coverage level that they need, because while most of our pre-65 Medicare folks typically fall into the public safety, we certainly have general government employees that fall in there as well. So we're all about providing equity to our members, general government, and our sworn officers,
Yep.
not eliminating pre-Medicare retiree health insurance. I believe that is, but one of the requests from Ms. Stagg was, well, what are some other people doing? I think you heard me kind of emphatically say last time, I'm all about finding low-hanging fruit options and sustainable options that allow us to provide comprehensive benefits all the way around. I'd rather make meaningful, smart choices now to address part of our OPEB liability and make this more affordable for our retirees, because that cost sharing component is getting ready to get significantly bigger for the, our growing majority of our population in the next 2 years. I want to make sure our retirees can afford our coverage, both pre-65 and post-65. And I want to make sure that everybody has access to that coverage. So I'm not interested in not addressing the OPEB liability and then things getting to such a point that we have to do something drastic, like eliminate retiree health care. Because as far as I'm concerned, that's a non-starter for me as well. So I completely agree with you.
Are there any other questions at this time? Ellie, I'll turn it back over to you.
Okay, I'm going to take a moment to stop sharing and open up the next document. So give me just 1 second.
Okay, so you're moving on to item number 3, Kelly?
I think so, unless there was any more questions about that.
Okay, yeah, it does. I don't see any hands raised. So item number 3 on the agenda is the Metro Code change for PPO.
Okay, let's see.
I'll let you open that up and then, all right.
All right. So Metro, this is just to ask the committee to consider removing some specific PPO language that's in Metro's Code of Laws. And when back in 1963, when the Metro Code of Laws was drafted, it actually had language that defined what the out-of-pocket maximum for the PPO plan would be. And that language remains the same here 57 years later or so in 2020. And it's defined as, in network, $1,000 for single coverage, $2,000 for family coverage. Out of network, $5,000 for single and $10,000 for family coverage. And by having the language in the code, it prevents the Metro Benefit Board from being able to have the flexibility to make plan changes that as they're looking to make sure the plans remain affordable and to keep the plans typically with in order to control the cost, you can either tweak plan design or you can just keep raising the cost of coverage. And so you may recall one of the items that we shared early on with you was a workforce insight survey that was done last year. And many of the younger employees or those in a lower compensated group of employees were interested in maybe more affordable health insurance from Metro. And so as Angela mentioned, we have been sharing some ideas with the benefit board at the October study session and the November study session. And the board would like to continue evaluating next year. But by taking the language out of the code, it will just give the benefit board the flexibility to be able to make changes should they decide to do that as one of the options as they're looking to move forward. So really and truly, our thought is that plan design language does not really belong in the city's code of laws. And so we're just recommending that amendment to take this specific code section out, and you can see the language down here that's spelled in down at the bottom is the actual language that's in the code.
Mr. James Smallwood, you have your hand raised. You are recognized.
Yes, thank you.
You know, I got to believe that when this was written into the code, that the authors that created this language knew why they were writing it in there, and it was to prevent something from happening like what we're seeing now. And I certainly understand that costs are increasing, but to put an arbitrary no limit on increases, I think puts our employees at an unnecessary risk. And also, I've heard a couple times now about a low-cost healthcare plan, and I know I have a lot of concerns about what that may do to our other plans, as well as the fact that I think our employees are looking for more affordable coverage, but I don't think they're looking for diminishing health benefits, and that is a concern as well. If we may be offering a healthcare plan, or maybe considering or discussing offering a healthcare plan that offers less to our employees and certainly costs less, but I don't think that's what our employees are looking for. I know certainly mine are not looking for something that would reduce their benefit.
This is Dick Chapman. I kind of agree with Mr. Smallwood in part because if you set up a low benefit plan and let people migrate into that, when they figure that they're going to have, for example, coverage for having a child, they're going to want to migrate back into the more generous plan. So you're going to have to set up limits on ability to move back and forth, because you're going to have people who are younger who are going to want to be in the lower cost plan, and then suddenly they're going to want to move when they can see an expense that's right over the horizon for them. The other thing is, I need to apologize for sending information to the committee members that dealt with deductibles, because I misread this chart, because it's the out-of-pocket maximum, which is a back-end deal, not a deductible, which is a front-end deal, because these numbers for an out-of-pocket maximum are pretty low. So I send information to the committee members and a few of the staff members today that dealt with the wrong topic. So I apologize for that.
Yeah, these out-of-pocket maximums are very low in today's world. And they were, in the 60s. I mean, they were put into place, but they're very generous. They're very low, and the problem that they've created is the cost of Metro's two plans, the PPO plan and the Cigna Choice Fund, are becoming very cost prohibitive for some of the Metro employees. And the other issue is that Metro requires employees to take coverage. If they're hired at Metro, unless they can show proof of coverage that's not Medicare, they have to take Metro's insurance. And I think that Metro Human Resources can attest to how the vocalness that they hear at new hire meetings at the cost of coverage. So it is, this is not going to say that the out-of-pocket maximum will change, because that all would be left up to the benefit board. But I think what it's doing is allowing the benefit board to have control over what the plan designs are going forward.
This is Dick Chapman again. Is this one of the few places where the Metro Code actually sets a specific benefit?
I may let Metro Legal or address that. I'm not 100% certain that I've read the entire code that could tell you that, but
Hey, Kelly?
Yes.
This is Shannon Hall. So let me say it this way, and I certainly don't want to be confusing. Mr. Chapman, the Title III of the Metro Code outlines a lot of benefit provisions, a substantial amount. Some sections of the code as we've talked about, we have comprehensive benefits, medical benefits, dental benefits, supplemental benefits, pension benefits, disability benefits. So there's a lot of benefits, and a lot of those have a home in Title III of the Metro Code. Depending on the benefit and the section, may have more or less detail because it might be necessary for that plan. One of my examples I would give is our pension and disability system. There's quite a bit of detail about how that, because we've structured that benefit, we administer that benefit in-house. There's quite a bit of detail that helps to provide structure so that you don't monkey around with someone's pension benefit or disability benefit, how we calculate, et cetera.
Right.
So there is quite a bit of detail actually in the Metro Code. What is interesting about the medical plans is the medical plans having this specific kind of language is unusual in the Metro Code, right? Our ability to provide Metro health insurance, the cost sharing provisions, that should be in the Metro Code, and that makes sense. But most of our other plan provisions are actually not codified in this exact same way. So for example, on our account-based plan, there may still need to be a legal review process that's blessed by the council, but really allows the board the authority to make plan determinations to meet its employees' needs. And I think that's the intent of asking about this change here. I think Mr. Smallwood raises some really good points. And right now, I think the board, and I'm a member of that board, have been contemplated heavily about how do we meet a growing employee need for affordable healthcare coverage in a responsible way. We kind of talked globally on the board level the past 2 months about kind of 3 ways to get there. And one of the big asks that I had the board is, this is the #1 complaint we receive from employees. We have substantial data, independent data, that shows the percentage of pay that our health insurance takes up on a gross pay for a huge part of our population. And that issue, because of rising healthcare costs, and frankly, our healthcare costs don't grow, are pretty modest in their growth, I think, versus a lot of other big organizations. But our pay raises can't keep track. So we're about to make our problems worse down the line. So I think the board is contemplating whether or not a third plan's offered. I think another way of getting there is modifying the current plans in a way to provide a more affordable healthcare premium on the front end, and allow people, once you pay a premium, it's a sunk cost and you don't see it again. That really, it disincentivizes, and it's a sunk cost, so the employees don't have the ability, if they need that access of healthcare, they've paid a lot on the front end and they still have to pay as they're using it. Well, for the people that don't use it or use it responsibly through the year, they still face the sunk cost. So I think Mr. Smallwood raises some really good points that I agree with. I think what we're looking for is opening up options so the board can make responsible decisions. And this code language prohibits them from doing so, at least on a PPO, at least evaluating another structure. And to Kelly's point, I'm not sure that an out-of-pocket maximum may or may not change, but frankly, having a plan with no deductible is fairly unusual 50 plus years later. And we showed a lot of that data to the Employee Benefit Board recently, and I think we may have shown some of that earlier to the Study and Formulating Committee, showing what our peers have been doing. And their costs, their premium cost and their cost to employees are significantly less.
This is Dick Chapman. Ms. Hall, do you know how many people cross over these out-of-pocket maximums every year?
I don't, but I'm sure we can get that data.
That might be helpful for putting some of this in perspective. And to the extent that they've got claims that are exceeding the out-of-pocket maximum, can maybe you put some brackets on the information of people who exceed the out-of-pocket maximum to basically put this in perspective so that we as a group would know how many people would be impacted if, for example, the out-of-pocket maximum was raised for single individuals by $100 or $200, to give us a perspective of how much impact is out there, that might actually help Mr. Smallwood and us understand better what we're talking about.
I don't disagree at all. Hopefully, our Deloitte team can help us out with that and work with our claims administrators to get that, because I think fundamentally we're probably all after the same thing, right? How do we responsibly address an employee? And this is an employee ask. I mean, this idea of introducing a third plan or adjusting out-of-pocket maximums is not necessarily something that we went and dreamed up. This is the data that was given not only by the employee workforce insight assessment that we shared with you early on. It's the number one complaint we get from employees at every new hire orientation that we do every single week. And we know, looking at independent data on percentage of pay and how many people fall into, that honestly, probably in the next 5 to 7 years, more than 50% of our population, this is going to be well in excess of 10% of their gross pay, just their 25% of the healthcare premium. And I think we've got to be able to meet an employee's needs, because that's our entire reason for existing, at least on the employee benefit board side.
Yeah, particularly on family coverage.
Hi, this is Cleo Rucker. I have a quick question. I was wondering, are there any historical documents that say how these figures were determined? I know that may be a challenge pulling that, but maybe even if we work with Deloitte to see if we are talking about removing or changing the language here, we can have a recommendation that there's a determination made that we can connect what we are recommending with something instead of just pulling the language all together. So those are just kind of a thought that I had there.
And this is Nick Brazel.
Yeah, I'm sorry, Nick.
Sorry, I was just going to say real quick, and it may be, if there's a way that we can determine or calculate, what $1,000 in 1963, what that looks like today. I mean, obviously I feel like $1,000 in 63 is considerably more than it is now. I mean, I agree with Mr. Smallwood. I'm not really in favor of opening the door to allow that to be increased too much, especially when you've got in my opinion, other items like a deductible that could be modestly implemented, or even take another look at the out-of-network coverage and things like that. But I mean, if there was going to be a change through the code, limit that to just increase the amount that's limited, or establish like a percentage that you can only increase it by so many years. So anyway, those are just my thoughts.
Mr. Brazel, this is Shannon. I completely agree with you. I think, the goal here is that, and I think if you want to give a specific recommendation on this, if you guys so choose, if you want to do something broader, I'd be really open to that so that the board can really wrestle with those. I think, to your point, like having even a modest deductible, what we've been legally advised is, this annual out-of-pocket maximum would include deductible and coinsurance, right? So with these limits, we couldn't implement a deductible without lowering the coinsurance payment, if that makes any sense. So to your point, if it made the committee feel more comfortable, and I think it could be as loose a recommendation as we recommend that the employee benefit board modify the section to allow appropriate discretion on appropriate deductibles. And I think it could be that broad, unless Nikki tells us otherwise. I think this language, as we've been legally advised, means that, if you wanted to put a $500 deductible and keep this same coinsurance, well, that's $1,500, and that exceeds that out-of-pocket maximum. So I think the board's hands are tied at this point. So if you all had specific recommendations that you wanted to make to help limit some of that, I think what we're looking for are just more options for the board to consider, because I agree that this shouldn't be a huge cost shift, but doing something to help mitigate those rising premiums for employees is really what the goal is.
Are there any additional questions on this slide?
And I was just going to add one more thing on what Mr. Smallwood was saying. I also have concerns about opening up another, essentially what would be a fourth option, I guess, a lower costing option. And from the sense of how it would impact the people left in the other groups, experience-wise, and diluting those pools even further, and the administrative costs and how those could eventually be worked into their premiums for the people that are choosing to stay in the more comprehensive plans. I just wanted to say that.
And this is Dick Chapman. I agree with Mr. Braswell on this, particularly with the proviso that people are going to be wanting to migrate between plan options, particularly at instances where they can see healthcare costs that they or their family is going to incur. They're going to want to shift into the more generous, more expensive plan at key points for themselves. And, they'll actually, I've seen this occur. They'll actually plan when the birth of a baby is going to take place because they can migrate on January 1st into another option that's more beneficial for them, or they discover that a family member has got a chronic disease and they're going to want to migrate to their own advantage. And, that's completely understandable, but you gotta pay attention to that because you're going to change the composition of the group that's underlying the cost of the benefit package.
I would just note to remind everyone that these are fully insured plans. So the pool stays the same. The pool of the population stays the same because all the plans would be fully insured by Metro. So I understand your point.
But the premiums, are the premiums different for each of the options that's available to the active employees? The premiums are the same.
The premiums, but are you talking about the premiums of the PPO plan versus the Cigna Choice Fund?
Correct.
They're different. The premium cost is different.
Right. So if Metro offered a third option that is a lower benefit, lower premium plan, but didn't have some impact on migration between the various options, that may drive costs for the lower benefit plan down. But if you don't prevent migration out of the lower benefit, lower cost plan back to the higher benefit, higher cost plan, you can have people transfer based on anticipated healthcare costs.
I don't know if...
I was just going to say, and you'll also be pulling, from the groups that are already there. I'd assume majority of the people that want to go to the lower costing health plan would be younger. And they're the ones that need the benefits less, but they're also the ones that kind of, supplement the people that use the other benefit plans more. So you're pulling healthy, younger lives out of there, and they're all pulling in one cheaper plan. And I understand that Metro pays, it's all paid by Metro, and it's not insured. But then also I assume that there's, administrative access fees to get into these networks, and those would also be affected by the amount of lives that are covered, under Cigna or under Blue Cross.
Mr. Brassel, Mr. Chapman, I think to your points and Mr. Smallwood's point, we agree that trying to mitigate adverse selection is very important. So I want you to know that that's part of the discussion that's happening with the board, our strategies on how you mitigate adverse selection between the plans. We've also tried to be really thoughtful about even entertaining a third option to help mitigate those. So for example, pregnancy is not subject to the deductible. So we've tried to adjust certain things, but I think to Angela's point, because all these plans are self-insured, it'd be great to pull the risk together. And these are the kinds of discussions that I'm really requesting that the board kind of formally look at. We should really pool our risk together and make responsible decisions about how we set rates across the plans. That could be a way to mitigate that. But I think to your greater points, if we don't offer a lower cost plan option, then that's all the more reason why we need this current language adjusted in the code for the current plans. So we're not magically just going to reduce the cost of premiums for employees by doing nothing. So our choices in loosely that we've discussed with the board are, do we offer a lower cost plan option, which is something the board's considering, and trying to weight things like how do we adjust certain coverages subject to deductible, not subject to deductible, to help mitigate part of that adverse selection. What other strategies could we look at? Two, we could adjust the language here on our current plans that allows the board the flexibility to set maybe a modest deductible on the plan or adjust out-of-pocket maximums as appropriate, but allowing the board to go through a robust discussion also with our employee groups as well to kind of determine that. Or three, start letting the groups kind of bear their own risk. And what I mean is active employees pay what their risk is, pre-retirees pay what their risk is, and post-Medicare retirees pay their risk. The only ones I think in that scenario that are going to stay consistent are those Medicare retirees, because even with Medicare, every dollar they put in, they get about $1 claim advantage out. That pre-Medicare population, their cost is going to escalate tremendously. And then when you layer on that new cost sharing requirement that's on the horizon, I think we're going to put that group in a major disadvantage. It would lower the active employees because the actives essentially subsidize that pre-Medicare. As we kind of discussed at the last board meeting, and I verbally said I agreed, you know, the retiree representative on the board said he certainly was not in favor of us adjusting the active subsidy to the pre-65 group. I agree with him. That's probably the least attractive of those three options. So our options are really exploring a third healthcare plan option, which I think Mr. Chapman, Mr. Brazel, and Mr. Smallwood all raise legitimate points about on adverse selection and trying to make sure we find strategies to mitigate that. Or we have to adjust some of this plan language so that the board can make plans that our employees can afford. So I do feel like that last option is not something that I'm necessarily in favor of. I verbally said that the last meeting. I know that the retired representative on the board, who is about as seasoned as anyone I know, I mean, he was the fire representative for decades. He knows his stuff. He also thinks that's not the best, and I can't disagree with him on that. So I do leave this to the committee's kind of discussion, but I think we have to open up a recommendation so this language can be adjusted if we're not going to introduce a third plan
option. And again, I just want to be clear. I'm not against adjusting or, I mean, really, yeah, I'm not against doing something with that language. I just, something that's been in there for 60 years and you've had that out-of-pocket maximum at that level for 60 years, I'm just uncomfortable removing it wholesale, I guess. So it's not that I don't want to, you know, I want to spend some time thinking about it and trying to run some scenarios and things through my head. I'm not comfortable just saying, yeah, remove it entirely, I think is what I'm trying to get at.
Mr. Smallwood, you are recognized.
Yes, ma'am. I just want to provide a little bit of clarification on my statement earlier. I can certainly understand the need to have a discussion about amending this code language, but and I think as others have already reflected, removing it completely opens a door that we may not be able to recover from. Imagine if tomorrow we found out our annual out-of-pocket maximum was $10,000 instead of $1,000, to mitigate the cost of a plan. And then again, having a low-cost plan where folks will migrate to that plan because they see a lower cost benefit, not realizing the adverse impacts of having a lower benefit available to them until later in life when they may need it, which will then drive the cost of the better plans up. And those of us who have chosen to maintain those plans will no longer be able to afford them. And then we'll all be stuck with the bargain benefit and not be able to have that better benefit, which is what I would like to believe attracts and retains a lot of our employees. But again, I can understand the need to amend some of this language, but opening it to a no limit, no holds barred is a huge concern of mine. And I think we're dancing on a very slippery slope here.
Mr. Brad Rayson, you could identify yourself and you're recognized.
Hi, this is Brad Rayson with SEIU Local 205. I agree with James and the comments that have been made by Mr. Brassel about going slow in this analysis. A benefit plan is a sum of its parts, and you start tinkering with one part, it has implications for other elements in the plan too. And I believe Mr. Chapman noted some of those things too, and some of the information that he was suggesting is what are the implications of any kind of changes to the out-of-pocket maximum are important considerations. But then there are other parts of the plan that would be, the benefits would be affected clearly by changing that number upwards, particularly. I guess I'm not aware of any call from the benefit board in any time in the past that they feel like they've been shackled by these code provisions that have been in effect for a long time. So that's something that kind of takes me by surprise, that something that's been in the code since 1963. I haven't heard anybody on the benefit board said, boy, I wish that was out of our, we didn't have to deal with that.
This is Dick Chapman. I would also observe that half of the benefit board is made up of, well, actually more than half is made up of covered employees. You know, the benefit board, if I remember correctly, is 10 people, 5 of whom are elected by the individuals who are covered as employees. The finance director is on there by a provision of the code and is likely a covered employee as well, although they may have divided frames of reference here. And I think the other 4 people are basically appointed by the mayor, some of whom may be covered individuals as well. Not that removes all of the various perspectives, but it also puts the employees in charge of half the votes. And removing this particular limitation wouldn't necessarily force any of the 5 employees. And I don't remember if Mr. Smallwood's one of the people who sits on the benefit board as well, but I think there's somebody from the police department who sits on the board. None of them would be required to move the out-of-pocket limit beyond the amount set today if they chose not to move them.
Mr. Chapman, that's correct. Half of the members of the board are employee and retiree representatives.
Right.
7 of the 10 are covered by Metro benefits. So it would be the 5 employee members, the director of finance, and the director of HR.
Yep.
And I think to everybody's points, because I think they're very good ones, Mr. Chapman, yours, Mr. Brazel, Mr. Smallwood, and Mr. Rayson. Again, I don't know that we have to have a recommendation to eliminate this language. I think allowing the board the option to modify this language with specific modest recommendations, or we recommend that the board contemplate making appropriate modifications to the out-of-pocket max title as outlined in Title III. I think that's a recommendation. I certainly wouldn't want anybody on the study and formulating committee to make a recommendation they weren't comfortable with. But I think we're not bound by, I think there's lots of options there to do so in a responsible way should the committee choose to do so.
Yeah, this is Dick Chapman again. I think the council trusts the benefit board and its current composition to basically do things that are, in the interest of employees and the citizen taxpayers who are paying part of the freight.
Are there any additional questions, comments on these slides? Kelly, is that the end of y'all's second presentation?
Yes, it is.
Okay. Okay. If there are no more questions or comments, recommendations, I will move on to item number 4, which is as someone else have a comment? No? Okay. As I mentioned before, our committee chair, Trish Holiday, has moved out of the county, so she is no longer eligible to be on our committee. So I would like to open the floor if anyone has any nominations. I know we only have a short time left for this committee as it wraps up in mid-February. So we will probably start talking about when recommendations should start to kind of possibly be made. Of course, y'all can make recommendations as you please. You can do it throughout the study and formulating committee meetings. You can wait till the end, however the committee chooses to pursue that. But we will, February 17th, I believe, is the date. So we will have subsequent meetings, hopefully a couple in January, and then we are trying to get one more done here in December. That being said, someone that would like to be the chair of this committee, or if anyone has recommendations or a nomination, we will take those at this time.
Hi, Christina. This is Cleo Rucker. I can move, would move into the chair position if,
okay. Is there a nomination for Mr. Cleo Rucker to become chair of this committee?
This is Kim Stagg. I will make that motion. Thank you, Mr. Rucker, for agreeing to serve.
I'd like to second that nomination.
Okay, so we have a motion and a second for Mr. Cleophas Rucker to move into the chair position. Let's take a vote. Nick Brazel.
Approved.
Mr. Chapman.
Aye.
Mr. Rucker.
Aye.
And Ms. Stagg.
Aye.
Okay. Since a vacancy has arisen, we will take nominations for a vice chair for the committee. Are there any nominations?
This is Nick Brazel. I nominate Mr. Richard Chapman.
Okay.
And I second that. Yeah, I second that nomination.
Okay, thank you, Mr. Rucker. Okay, we have a motion and a second for
this is Dick Chapman. Just for the record, I agree.
Okay, we're going to take a vote, so you get to do it on record. Nick Brazel.
Yes.
Mr. Chapman?
Aye.
Mr. Rucker?
Yes, I agree.
And Ms. Stagg? Kim Stagg?
Aye.
Okay, wonderful. So we now have a new chair. Congratulations, and new vice chair. At this time, since Mr. Rucker, I don't know if you're okay with me kind of asking next steps. I know as the chair, you can kind of guide us to where you guys want to go. It does appear I've done a little bit of work ahead of time, and it does appear that probably the last time we could meet for this committee would be on December 14th, before there's a lot of holiday breaks and a lot of people that are going to be going out of town around 9 a.m. As soon as I firm that up with all the possible entities that will need to be involved, that is a date that we are looking at, and we'll have to make pretty much a decision on right away. But all the committee members are available on that date and time. I would like to kind of hear, and Cleo, please chime in as you see, but what the next steps for the next meeting would like. We have had someone, a council member, ask us to present some information at the next meeting. So that is something we will probably put on that agenda for December 14th, since we have had a request. And I know there were some questions today. Mr. Chapman, Mr. Rucker, Mr. Brassel, y'all kind of had some questions of things I think Deloitte could probably research and bring back. Is there anything else that we can put on this agenda or next steps that you guys want to see before the new year, since we will have probably 2, maybe 3. I don't know if we could do 4 before February 17th. But we want to go ahead and get what you guys want to do in as soon as we can.
Thank you. I think that, that's getting the information back from Deloitte would be great. But I also think if we just had time to really just see kind of where we are, just generally, we've had a lot of information over the last couple of months provided to us. And I think we can, really discuss just next steps as it relates to what has been presented and where we're kind of leaning and even discuss a bit further about some of the recommendations we talked about today. So that would be my thoughts. I don't know what will be some thoughts of the other committee members.
Okay, this is Dick Chapman. One of the things that we've discussed is PSDT kind of stuff that relates to the OID instances. And there's been some discussion of the fire department has put in place some new stuff, but we don't have any description of what that is. If you guys could put together from a staff level just some information about what the fire department's doing in relationship to that. Also, some information about what the police department has done about that issue. And also, perhaps if any other place is doing any work in response to employees' concerns about those types of what I want to call injuries on duty that relate to PSDT, that would be helpful, at least from my perspective, to maybe putting some recommendations together to perhaps consider what the fire department's doing and monitoring that, putting that together, and perhaps what the police department currently does, and perhaps any other places like in the sheriff's office or in the 911 dispatch group that I looking at think might have a greater exposure than some of the general workers for that type of impact on people in their jobs. That would be helpful to kind of look at that from my perspective.
And I would just say I agree with what Mr. Rucker was saying. I think after all the information we've taken in over the last several meetings, it'd probably be good to have an opportunity to catch our breath and, actually discuss amongst ourselves, what our thoughts may be for that.
Any other thoughts, comments of items or items we've already touched on?
There was one additional point in the finance director's memo to us related to, I believe, exploring education programs for Metro employees related to financial management. Is that correct? I don't recall that we've delved into that issue. Was the thought that we would not broach that subject, or is there an expected presentation forthcoming on options?
This is Dick Chapman. I've looked at a couple things that I'd like to maybe put out to the board, and I can have that ready in a week.
Thank you.
And the other thing is, I promise to make it on the topic that's supposed to be there, not something else.
Mr. Chapman, is this things that you've put together as far as what Ms. Stagg was asking on education programs, or is this
Yes,
okay.
specifically on education programs? The state of Tennessee's got a financial education website in the treasurer's office. I can outline some of that to the board members, or committee members, I'm sorry. And I'll also check with the person who's in charge of that in the treasurer's office to make sure that if we want to do a link up on that, that's something that they would agree to.
Any other questions, comments? All right, with no further business for today's meeting, this meeting is now adjourned. Thank you all.
Thank you.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information about this and other programs, visit nashville.gov.